Welcome, everyone. My name is Yvette Gaughan. I am a Medical Affairs Associate Manager with Nestle Health Science, and I am delighted to introduce today's speaker and assist with the webinar, Strategies for Improving Enteral Nutrition Delivery in the ICU. Today's speaker, Dr. Darren Hyland. Dr. Hyland is a professor of medicine and epidemiology at Queen's University in Kingston, Ontario, Canada. He completed training in internal medicine, critical care medicine, and clinical epidemiology. He currently serves as the director of the Clinical Evaluation Research Unit at the Kingston General Hospital, which functions as a method center for multi-center clinical research. He is the principal investigator on a number of large-scale multi-center clinical nutrition research projects, the lead author of the Canadian Critical Care Nutrition Clinical Practice Guidelines, and the sponsor of the International Nutritional Survey that audits nutrition practices worldwide every year. Dr. Hyland has published approximately 300 peer-reviewed papers. He's raised more than $100 million in external grant support and delivered over 300 international presentations. And so with that, what I'd like to do is turn it over to today's speaker, Dr. Hyland.
Thanks, Yvette. And thanks, everybody, for joining us this afternoon. I'm excited to have this opportunity to dialogue with you about strategies for improving enteral nutrition in the ICU. I think we're in a period of confusion, if not crises, in as much as we've had a lot of large negative randomized controlled trials published recently in the critical care nutrition literature, so much so that some experts are advocating for fasting or for long periods of permissive underfeeding in our community. And that, I think, is causing some of us on the front lines that deal with critically ill patients day to day some confusion. So I hope today to bring some clarity out of that confusion. Aside from being an intensivist and someone with some interest in critical care nutrition, I'm also a clinical epidemiologist, and I understand randomized controlled trials, how to design them, how to interpret them. I understand evidence and how to judge the validity and weight of such evidence. And so I hope to sort of give you, my views on this evolving literature in this space, where I will have a conversation with you about not all ICU patients are the same, and we need to be a bit more discriminatory in our identifying those patients who will benefit the most from our nutritional interventions. I'll describe the optimal amounts from my viewpoint of protein calories to support the best outcomes of our patients. And then that'll lead us into some practical discussions of how to and what's the best way to do that, to deliver optimal amounts of nutrition. And I'll specifically mention volume-based feeding and the PEP-UP protocol as we wind up this presentation today. So the latest breaking news is that perhaps the early provision of high protein is harmful, and whether volume-based feeds, that they should be avoided. These are what experts are publishing in the literature today, and I, again, hope to bring some sensibility to this conversation to help you as a practitioner or as a listener today discriminate the difference between fake news and fact, or when we're uncertain, and that's what my objective is today. To start with the evolving narrative that's coming from some experts about how, hey, we should start slow and ramp up slow and have modest targets for the first early phase of critical illness, without really being able to define when that early phase is. I'm giving you an example of a protocol that's being talked about in the literature, where the goal really isn't to meet the protein energy or the protein requirements in this instance, in this slide, until day 5 to 7 or beyond. And that's coming from some data points that the protein may be harmful in that early phase. And I'll review those data points and discuss them with you. But, I'm old enough say that this is exactly how we used to feed, 20 years ago or 10 years ago. And I would have thought some of the innovations that we've made in the last decade is to actually do away with the slow startups and slow ramp ups. And so I disagree with this idea of going back 20 years to the slow startups and slow ramp ups, because I think that's associated with poorer outcomes. Having said that, there are a few data points in the literature that people conclude that protein is harmful, and particularly in the early phase. And the strongest evidence for that assertion comes from these data from the APANIC trial. You know the APANIC trial. It's the randomized trial done by the Belgian group of early versus delayed parenteral nutrition, where the inference from the overall RCT was that early PN is harmful, ought not to be done. And then in this post hoc analysis, they show data that the protein received in the first 3 days is associated with the lowest likelihood of ICU discharge. So that's what the y-axis reflects. And what I'm showing you on this data point is the amount of protein received within the first 3 days is associated with a lower likelihood of earlier discharge. So not glucose, not protein received later on, but within the first 3 days. And so from that, and this, to this credit, this group has gone off and done a lot of work to explain mechanistically why that might be. It has to do with suppressing autophagy, and that amino acids are having a negative impact on those amino acid sensitive pathways. I would like to argue that that is possibly a flawed interpretation of these data points. This is an open label randomized controlled trial, and they're showing us a post hoc analysis where they're relating nutrition intake to outcome. Clearly, the longer staying patients are going to be fed more aggressively. This is a trial of mostly elective surgical patients. So the patients who are sicker, the more critically ill of the patients, are going to get more protein. They're going to get more enteral nutrition. Because remember, before day 3, patients in the PN strategies did not get parenteral nutrition. They got glucose only. And so there was no parenteral nutrition received before day 3. So all of this comes from the enteral route. So who would, of a large trial of 4,000 patients where they're mostly elective surgical patients, the people who are going to get more enteral nutrition, more enteral protein, are sicker patients. So it's an indication bias. Sicker patients get more protein, have a worse outcome. The most robust, valid interpretation from the APANIC trial is from the randomized part of the trial, where you look at the two groups side by side, and you see that there are significant differences between the late group and the early group. And so the authors conclude that, late is better because there's a lower, a difference in the mechanical ventilation, duration of stay. But I want to draw your attention to the fact that those differences are apparent by day 2. So the difference in duration of mechanical ventilation by day 2 is significantly different. It's worse in the early EN group. And again, I draw your attention to the fact that the PN didn't start till day 3. So these are differences that are apparent by day 2, or in this instance below, when you're talking about duration of ICU stay by day 3. So what could have caused the difference between the two groups before day 3? It has nothing to do with PN, because the PN didn't start till day 3. So it had everything to do with large glucose loading under conditions of tight glycemic control is harmful. So that is the strongest inference that we want to make from the APANIC trial, that in low-risk cardiac surgery, mostly patients, giving large glucose loads under conditions of tight glycemic control is harmful, and any sort of signaling that protein is harmful is a flawed inference from a post hoc observation. To further my point, I refer you to, and we won't have time to go through that today, but there are 2 other large multi-center randomized controlled trials looking at the role of early PN, or PN in the early phase of critical illness, where patients would have got both more protein and more calories, and there was no signal of harm. So we could argue about the benefits, of which there were putative benefits with these strategies, but that's not the point of me showing you these data or referring to these data. My point is to refute that there's a signal from harm from early administration of parenteral nutrition in the main instance, and protein specifically, from these two RCTs. The other trial that causes some confusion is the INTACT trial, where a small number in a single center, patients with ALI were randomized to a very intensive medical nutritional strategy, up to 35 calories per kilogram per day, versus usual care of only 40 to 60% of the targets. And as you may recall, that trial was stopped early because of excessive deaths in the intensive group. And so now the investigators have come back with a post hoc analysis showing that the amount of protein received in that early phase, day 1 to 7, is associated with a large increased hazard ratio, increased risk of dying with increased amounts of protein received in the first 7 days, and not after that, but rather just in the first 7 days. So again, suggesting that early protein's harmful, late protein's fine. And we have to put this in perspective that this is a small single center RCT that was stopped prematurely. There's lots of literature out there to suggest that these trials that stop prematurely are likely to overestimate significantly the treatment effect. And I don't think that one trial from one center should uniformly influence practice patterns worldwide. Moreover, that was a problem with calories in the RCT. Too many calories, mostly from lipids, where there was a lot of overfeeding, is what caused the harm. There was only a modest amount of protein, 82 grams or less than 1 gram per kilogram per day delivered in that trial. And so we don't have any other data points elsewhere from randomized controlled trials that protein is harmful. So something's, flawed in this analysis, where patients were significantly overfed with a lot of calories from parenteral lipids being received that caused excess mortality. I feel like it's more consistent, looking at the other literature, that overfeeding with parenteral lipids, particularly propofol, soybean emulsion lipids, is harmful. We know that. So that's explaining the harm from this trial. And it's not likely to be a modest amount of protein, even received in the first week. And I'll come back to other claims from RCT levels of evidence that protein in the first week at higher doses than this is safe. So the third data point in the literature, again, these are recent publications, where in a single center retrospective database, my friend and colleague Arthur von Zanten and his colleagues went through and described the nutritional intake and divided it into tertiles, and lower dose protein less than 0.8 compared to 0.8 to 1.2 compared to greater than 1.2 overall, and didn't really see any difference in the survival curves of the three groups. So they, in a post hoc way, in this retrospective single center study, did another analysis by time. And what they're showing you here in this figure is that overall, this is cumulative survival. And if you were underfed less than 0.8 grams per kilogram per day overall, you had a poor survival. However, if you received more than that, greater than 0.8 grams per kilogram per day, you only had a modest survival. Or said differently, the best survival came from patients who had less than 0.8 from day 1 to 3 and greater than 0.8 from day 4 on. And so this is what has led to the evolution of the thinking that, we should slow start up, slow ramp up, and only worry about after day 3, getting optimal protein intake. And whilst that might be the case, the idea of a slow startup is actually associated with significant underfeeding, and I'll come back to that point when we talk about volume-based feeds. So I want to just stress this point here from this slide, that not all data are the same, not all evidence is the same. We strive to make inferences about how to manage patients in our clinical practice guidelines from high levels of evidence where there's less likely to be bias. And that comes from randomized controlled trials or meta-analysis of randomized controlled trials, or perhaps, the weakest level of evidence we might consider would be from, large multi-center prospective cohort trials. So far we've reviewed post hoc analyses or a single center retrospective data set analyses. And I would submit those are hypothesis generating observations at best, that they are likely to be biased, and that we ought not to make clinical inferences on how we manage patients from that level of evidence. Higher levels of evidence are required before we're going to make inferences about managing patients. Moreover, if you've heard me talk before, you'll know, and you probably have seen this slide, and you're probably sick of it, that one way of interpreting or explaining the negative studies that have been published is the lack of consideration of nutritional risk, that not all patients are created equal. And so when we take large heterogeneous groups of ICU patients and expose them to a nutritional intervention and we don't see a treatment effect, is it because nutrition doesn't matter? Or is it because, there's some patients that are benefiting from the more nutrition, there's some patients that are having a neutral effect, and there's some patients that are having a negative effect. And when you put those in the blender, you come out with nothing. We call this heterogeneity of treatment effect. There's a different treatment effect experienced by different, subgroups of patients. And conceptually, we step back and say, well, what would be the key determinants of how a person will respond to nutritional intervention? Well, it'd be a function of their pre-existing malnourished state or measures of starvation or underfeeding, both in the acute and chronic way, as well as the degree of inflammation or their severity of illness. And there are metrics that we can quantify that in both the acute and chronic way. And so conceptually, that's how we developed what we called the Nutrix score. I'm sure you've heard me talk about the Nutrix score. For those of you who haven't, it's one of the things that helps us discriminate the people that may respond better to nutrition than those that don't. If you've got a low Nutrix score, there's as you increase nutritional adequacy, there doesn't seem to be any relationship to mortality. In contrast, if you've got a high Nutrix score, as you increase nutritional intake, that's associated with a reduction in mortality. So high Nutrix scores tend to benefit from more nutrition compared to low Nutrix scores. I respect that this is sort of a new idea, perhaps even a controversial idea. I want to use this slide to communicate to you that there's been a lot of work worldwide on developing and validating this concept, not just in my database, but in other databases, in other patient groups around the world. I will acknowledge that in the PERMIT trial, which is a trial of different doses of calories, that they were not able to see a differential response in high Nutrix versus low Nutrix, although the confidence intervals were really wide, and so it didn't rule out an important effect. But more importantly, I would submit to you that it's about protein and not calories, and so that's what would really matter. So I'd love to, if I was looking in your eyes in a face-to-face audience, I would use this as an opportunity to ask your reflections about the Nutrix score, and if you're using it, if you're not using it, if you have questions about the Nutrix score, please enter that into the question panel, and we can come back to that at the end of the presentation. Or if you just have a comment or want to share with me why you don't use the Nutrix score, I'd love to hear more about your lived experience with the Nutrix score. I assert that these data are the strongest data that support how the Nutrix score discriminates responders from non-responders. And again, this is a post hoc analysis from a prospective randomized controlled trial where we top people up with enteral versus enteral plus parenteral. And in the subgrouped patient with low Nutrix, you can see, first of all, that their mortality rate is pretty low, but also there's no difference between the supplemented and non-supplemented group. In contrast, when we look at the subgroup of people who had a high Nutrix score, again, you see that their hospital and ICU mortality is very high, but that there's a large differential treatment effect in those patients who got supplemented, who got more protein, more calories. They had a large reduction in mortality. This is a pilot study, and it's a subgroup analysis. The p-value here is not significant because it lacks power. However, it's a very provocative signal, a hypothesis-generating observation that is very supportive of what I've said to you so far, that Nutric seems to be able to discriminate those patients that benefit the most from more nutrition. I tried to say briefly a minute ago that it's not so much about calories, but optimal protein dosing. And let's just step back for a minute and realize that there's quite a bit of data that shows that early enteral nutrition is beneficial, both from providing optimal nutrient delivery, minimizing the protein calorie debt in that early phase of critical illness. But the far left of the screen, I'll give you a reference if you're not familiar with those non-nutritional benefits of early enteral nutrition. There are a lot of them. They're being proposed and summarized nicely by my friend Dr. McClave. And then to the middle and right of the screen, numerous randomized controlled trials showing a significant reduction in infections and a trend towards a significant reduction in mortality. That early provision of enteral nutrition is helpful to our critically ill patients. So don't lose sight of these data points as people start talking about the harm from early feeding in the other publications. You remember the Eden study, which showed early trophic feed, or compared rather early trophic feeding to early full feeding during that first week. And so there clearly was a difference in the amount of protein calories received by the two groups. And you remember that the result was negative. There was no impact of a more aggressive feeding approach compared to the trophic feeds. And that led some people to say, well, it's okay to just underfeed for 7 days and then worry about optimizing nutrition intake. The key point that I want to make from this randomized trial is that there was no harm signal. So if I choose to full feed, I'm not doing harm. You can't argue that there's a benefit from this data set. And I can explain, I've already explained to you why this might be, because of the lack of nutrition risk assessment, in these patients. But use these data to refute the idea that early optimal nutrition is harmful, and therefore we ought to go slow, we ought to ramp up slow. So you see how I'm using RCT level of evidence to refute the signals of harm from retrospective analyses or from post hoc analyses. I can now say that we can also use these Eden data to support a potential benefit. These are the 1-year long-term follow-up studies that assess the physical and cognitive outcome of the patients who got trophic feeding on the left or full feeding on the right. And although all these lines cross one, so there's no statistically significant findings, the top two endpoints, 6-minute walk test and 4-meter time walk speed, all the benefit lies to the right. 90% of the 95% confident intervals lies to the right. They're not statistically significant, but it's certainly a trend towards improvement with full feeding. And there are other experts that support this assertion that more protein, higher doses of protein, up to 2 to 2.5 grams per kilogram, is associated with a better outcome. No, we cannot prove that with RCT level of evidence. Here's an updated meta-analysis of randomized controlled trials that have looked at high versus low protein, and when you statistically combine those, it's associated with a risk ratio of 0.89, but the confidence intervals are overlapping. P-value there is 0.42. So really there's no signal here. Certainly not consistent with a signal of harm, but really you come away kind of empty-handed from the RCT level of evidence. There is one of those RCTs in there, the DOIG study, the NephroProtect study, that I think is important to consider. Here we look at a strategy of topping people up with just intravenous amino acids. And remember, the goal of this study was to preserve or protect kidney function. That's why it's called the NephroProtect study. So they enrolled patients at risk of kidney injury, exposed them to a higher dose of IV amino acids to get them up near that 2 grams per kilogram per day, So they had nice separation of the protein intake between groups. Both groups received standard enteral feeding, which means underfeeding, where they get about 0.5, 0.6 grams per kilogram per day. So despite that difference in group, they actually did not see an improvement in kidney function, with the exception of what could be argued as a not very clinically important improvement in the estimated GFR, but there really wasn't any difference in use of dialysis or, frankly, any other clinical income, including quality of life measures or survival. But again, we can use this RCT level of evidence to say in the early phase of critical illness, where patients got up to 2.0 grams per kilogram per day, there was no single signal of harm. So post hoc or retrospective small studies that are saying harm, when they stand against these RCTs that I'm showing you, we don't see that harm signal. In contrast, we see benefits of more protein in the early phase on muscle, and that's kind of important from a recovery point of view. This is Susan Ferry's work from Australia, where patients got 2 PN strategies, one with a dose of 1.2, another with 0.8 grams per kilogram per day of amino acids, and you see statistically significant improvements in hand grip strength, and then ultrasound measures of muscle mass, thickness of the thigh or thickness in other places. No impact on clinical outcomes, but this is a small study. So one small study showing favorable effects of more protein on muscle mass. A second study from Australia where they piloted volume-based feeds plus protein supplements, so kind of a version of the PEPOP protocol versus standard feeding, and they get pretty good separation of groups, sort of 1.5 grams per kilogram per day of protein versus 0.7, 0.8 grams per kilogram per day of protein, and the primary outcome being the primary outcome for this study was just the difference in protein intake, but as a secondary outcome, a better preservation of that muscle mass using the ultrasound of the thigh, looking at the thickness, that even when adjusting for baseline variables, there was a better measure, a thicker measure on the group that got more protein. So again, small study, single center, not expecting it to show a difference in outcome, but at least we've got two data points in the literature that early introduction of protein is leading to a better preservation of muscle mass. And we don't have RCTs that show that early protein is associated with clinical outcomes, so we're left with these trials, which I've been doing, that look at the relationship between protein intake and outcome. So we asked the question in our large data set, if you get more than 80% of what is prescribed compared to less than 80%, then that's associated with significant reduction in mortality. You can say the same about energy, except when we go to the right-hand column, we're controlling energy and asking the question about protein intake. So when I account for how much energy the patient received, and I still ask the question, did you get more than 80% of your protein requirements, you still see a significant reduction in mortality. In contrast, when I control for protein intake and I re-ask the question about energy, I don't see a relationship. I don't see a significant signal here. As if to say, again, meeting protein requirements is more important than energy requirements. So your optimal protein requirements, as defined by this slope from the same data set that I'm talking to you about, are perhaps a better outcome up until that 80% point, but beyond 80%, and certainly from other data points, if you overfeed somebody with calories, you're going to have a worse outcome. So the optimal dose of protein based on these data points and the RCTs that are been published late, somewhere between 40 to 80% of your energy prescription. But with respect to protein, the blue line, we don't really see the end of that line where it slopes up or even flattens out. And so it looks like more and more and more and more might be associated with a better outcome. I mean, I've been going through both observational studies that are saying, yes, this is helpful, and I've been also going through studies that say, yes, this possibly is harmful. And so in the final analysis, I will argue that there is a degree of uncertainty, that we're not totally sure, what the best answer is. I think that there should be absolute agreement on the need to do more research. And actually, I'll use that as a segue to introduce you to the EFFORT trial, which looks at this question of, does a higher protein prescription matter compared to what is usual care of 1.2 or less? And we're looking at 60-day outcomes. For those of you familiar with our international survey, this is a registry-based trial where we're nesting this randomization process in that international nutrition survey and constraining you to be prescribing either 2.2 or 1.2 or less. So everything else in the trial is the same as usual care, same as your usual practice, and the data that we collect are the same data that we've been collecting for the INS for years. Our hypothesis is that if you get prescribed a higher amount, you'll actually receive a higher amount, and that's associated with a better outcome. What's unique about this trial, in fact, is that we are only enrolling what we call nutritionally high-risk patients, and I'll explain that in a second. So the intervention, as I mentioned, is only the prescription, and we aren't specifying products or strategies or how you achieve that. We don't really even specify the energy dose, although we do suggest that you follow current guidelines with respect to energy. We get a lot of pushback from people saying, well, I believe strongly that high protein is helpful, and so I'm not willing to participate in your trial because I think the high protein is harmful, is helpful. Or we get pushback on the other side. So, oh no, it looks like protein is harmful, and so there's no way I'd want the high protein arm. And so there doesn't seem to be a lot of equipoise or uncertainty in our community. And to help with that narrative or that conversation, I'd refer you to a nibble that we just recently published on our website, where we sort of go through, in tabular and text fashion, evidence for, evidence against, equivocal evidence, and we kind of come up with the bottom line. There are these data points that are favoring that higher protein is helpful. There are these data points that are suggesting that it's harmful, and what we all should agree on is that we need more data. Where we think the money lies is in providing more or higher protein levels to nutritionally high-risk patients. And so that's the only kind of patient population that we're enrolling in this trial. And I've shown our inclusion criteria slide here, and I won't go through this in detail, other than just to say that you have to be 18 plus have one of those high-risk criteria and be mechanically ventilated for 40 or more hours to be enrolled in this trial. So conceptually, how it works is, as a dietitian, if you're screening your if you're going in the ICU assessing your new patients, and in the process of doing that nutritional assessment, you find somebody that meets these criteria, we're asking you to log on, push a button, they get randomized, you'd be told how much protein to prescribe, either 2.2 or high or 1.2 or lower. And then the rest of your management and the team's management is as per your usual clinical standards. And then we'll collect the outcome, and 4,000 patients later, we'll compare the differences between the two groups, and we'll have more information on the optimal dose of protein. In the meantime, I don't think it's reasonable to suggest a change of practice or to suggest a slowing down of the amount of nutrition that we've been giving people. And so I would refer you to the guidelines that still advocate for early enteral feeding, and frankly give a wide range of dose, including 1.2 to 2.0, because we don't really know any more precisely what the right answer is. So if you're right now prescribing 1.2, fine, keep doing it. If you're right now prescribing 2.0, fine, keep doing it. But I would prefer, rather than do that, that you enroll patients in the EFFORT trial so that we can sort out whether the difference of dose really matters. So I've given you some indication there on the bottom as to how, if I were you, I would probably aim on the low side for the first day to a week, but certainly after that, be very comfortable moving up to the higher side of that range. I would be minimalistic in my caloric delivery, or at least not try to achieve the high doses that have been used in some trials, or don't see a rationale for going beyond 80% of what you prescribe. And I would certainly be cautious about monitoring for glucose and electrolyte and phosphate stability as you're trying to reach those goals. So if you want more information on the EFFORT trial, please engage me electronically or check our website. We've got a lot of information on there that will help you understand what's required of you and how to get started. Let me just close by talking about perhaps a practical approach. You know, I'm the developer and promoter of the PEP-UP trial, PEP-UP protocol rather, where we have shifted the conversation from hourly dosing to 24-hour or 24-hour volume goal rather than a rate. And that enables the bedside nurse to make day-to-day, hour-to-hour adjustments on what that rate should be, because frequently, as you know, there are interruptions that preclude them from reaching goals. So we recommend a 24-hour volume-based approach. We recommend a semi-digested solution that will minimize the chance of intolerance and optimize the chance of that patient tolerating their nutrition. We recommend prophylactic and preemptive use of protein supplements and motility agents so that we can get ahead and get more nutrition in and optimize the chance of tolerance. There's some pushback around the motility agents, and I'll say to people, if your physicians don't want to use preemptive motility agents, that's fine. Don't just let that piece of this protocol go. Everything else still is worth implementing. And tolerating a higher GRV is also another way to optimize nutrition delivery. And we've got lots of data, both from this large-scale randomized controlled trial of 1,000 patients, where we saw a significant increase in nutrition delivery, 12 to 14%, with no overfeeding. We're still not hitting, 100%, but that's okay. I don't really think 100% is important. I think at least 80%. But if you start low and go slow, you're going to have significant underfeeding, whereas if you use a PEP-UP approach, you're going to have 12 to 14% better, but you're not going to be overdosing or overfeeding. We didn't show a difference in outcome here, but we weren't powered to do so, but there's no hint of a harm signal whatsoever by this approach where a PEP-UP or a volume-based feeding approach is used. Here again is another slide from our real observational study pre-post, where sites implemented, not in a randomized controlled trial, but just in a quality improvement project, the PEP-UP protocol. And you can see that it's not till day 5 or 6 that you're getting 80%. But that's better than usual care or the slow startup approach, where you actually never approach 80%. So if you start slow. So this light blue line is if you're kept MPO for the first days, you never reach 80%. You have a large protein calorie debt. If you have a slow ramp up, you'll still have a large protein calorie debt, and you won't reach 80% until about day 8. So the best way to sort of get to 80% by that day 3-4 window, where we think it is important, is a PEP-UP or a volume-based approach. So don't stop, don't slow down, keep going. But really, I don't think it really matters until day 3 or 4 when you do that evaluation. And I'll illustrate what I mean that in a subsequent slide. I think in the interest of time, I'm just going to skip that slide. I'll stress the point that in order to achieve optimal nutrition performance, how important it is to monitor success and report on success. So embed that into your daily practice, that you're tracking it, you're reporting on it, or your nurses are reporting it as part of their GI systems report, that they're saying, the patient received X% of that which they were prescribed to receive yesterday. If we can make that one of the discussion points and rounds, there'll be more attention to nutrition and more strategies to help people improve performance. We've got a tool on our website that enables you to, if you input the intake, you can get a visual that shows that caloric debt. You can bring that either on a handheld device or a laptop or a portable computer, or print it, and just help that visual become a talking point for you as a dietitian on how this individual patient is doing with respect to their protein or caloric debt. So let me summarize in this slide what I think is optimal practice today in 2018, and it frankly hasn't changed over the last few years, notwithstanding these post hoc and retrospective data points, because they are not practice changing. as I've shown you today, the RCT level of evidence to support early enteral feeding and early optimal feeding is still stronger than the negative points that I've reviewed with you today. Admittedly, it's not strong enough to be dogmatic. That's why we're doing the EFFORT trial, to try and gain more higher level of evidence of efficacy. But in the meantime, I think optimizing delivery using a volume-based feeding or PEP-UP protocol approach is warranted in all patients. I don't think it will matter in all patients, because if it's a low-risk patient, you know, who really cares if they get 40%, 50%, 60%? Doesn't really matter. But why would you use a feeding protocol that treats all patients as low-risk patients, you know, where you say it doesn't really matter? No. So you'll want to use a feeding protocol that optimizes delivery to your high-risk patients. And so everybody starts on a feeding protocol. They start early, but on day 3, or arguably you could say day 4, you come around and you say, are you getting 80% of your goal? And in this instance, goal protein is more important. And if not, and they're high risk, then you've got to do something. You've got to do something to maximize intake. And you've got to be considerate of those tools such as motility agents, small bowel feeding, protein supplements, and are you maximizing their use to get that protein up to 80% or more by day 3, by day 4. And if not, then consider the role of supplemental parenteral nutrition, again, only in that high-risk patient. If it's a low-risk patient, then that conversation isn't necessary. Continue to monitor, make sure they're doing a good job. If they're low risk, you may not fuss a lot on day 3 or day 4, but gosh, I would continue to monitor them, because they may evolve into a high risk or a long staying patient where nutrition becomes a lot more important. So I hope that that's clear and gives you both a conceptual understanding of the evidence and some practical ideas on how to achieve early optimal feeding, which from my books is getting feed started early within 24 to 48 hours of admission. Energy levels aren't as important as protein, but optimal levels are 80% in the high-risk patients dosed at that 1.2 to 2.0 grams. Considerate of glucose and phosphate levels. A hypothesis being that nutritionally high-risk patients will benefit the most, and it's in those patients where I think you really got to put your energies to track adequacy and be sure that you're optimizing delivery. I've explained tools and strategies, protocols, for example, where that you can use and implement, and I'll refer you to our website again, where you can get a whole suite of tools to help you implement volume-based feeding. And last but not least, I would certainly hope you would consider joining the EFFORT trial, so that you're doing your assessment, you're doing your work. You can actually be contributing to generating new knowledge, so that 3 or 4 years from now, we're so much further ahead, because as a collaborative, we're both answering the question about how to optimize patient outcomes at the same time that we're striving to do that in the practice. So thank you for your time. I'll turn the time back to Yvette to see if there are any questions.
Thank you so much, Dr. Hyland. What a very informative presentation. And yes, we do have some questions and some comments as you had requested. And what I'm going to do, Dr. Hyland, is just share a couple of comments that you had asked for in regards to the Nutrix score. So I thought I'd just share those first. One comment and or question is the Nutrix score requires SOFA and Apache 2 scores, which deters clinicians from using. It's kind of a trend here. I've got a couple other comments that talk about it's the time that it takes or the ability to access that type of information. So the question is there an easier way to obtain this information that could be used when calculating the Nutrix score?
Thank you for that question, and I totally understand the nature of the question or comment that calculating an Apache score and a SCOFA score is really not something dietitians are used to doing, and therefore is time-consuming, and it is a barrier to using Nutrix score. The easiest way to do this is to have a conversation with your IT people to try and have them extract that and calculate it automatically from your electronic medical record, assuming that you work in a place that has an electronic medical record. And as I've traveled around the country, I hear about a lot of people trying to do that. Now, I know that getting attention from an IT person to do something novel in your Epic or other EMR is not is an issue. It is a time-consuming process. But once that's in place, I mean, they could actually have the electronic medical record calculate the score automatically in its entirety. So I think long-term, that's a worthwhile conversation. On the short term, there are online calculators, and again, we've referenced them on our website, where you can just go to on a link, go to a calculator where you just enter in all the components of Apache and SOFA, and it calculates the score. And in fact, there's a Nutri-Score calculator that if you just enter in all the components, it calculates the score for you. But it still takes 5 minutes to find and enter in all those components. So I appreciate that it is a barrier. That's why it's not part of the entry criteria in the EFFORT trial. I don't know if you noticed that. I didn't draw your attention to it, but we use other nutrition risk variables than than Nutrix, because we feel like it would be too much of a barrier to engage in the EFFORT trial if we required you to prospectively calculate the Nutrix score. By the way, the other comment I forgot to say that I'm really interested in is any feedback you have for me about why you haven't engaged in the EFFORT trial, or struggles that you're having as you're trying to engage in the EFFORT trial. Because if there's something that I can say or do to make it easier for you, I'm very interested in that kind of feedback as well.
Okay. Well, in the meantime, we'll give the audience some time to share their comments about that question, Dr. Hyland. And so what I'll do is ask a couple other questions, and then I'll look back in the questions here and see if we have some comments about that as far as their engagement in the EFFORT trial. Here's a question. How would you account for those patients that are at risk for gut ischemia or with compromised hemodynamic status when you think about the importance of feeding early?
Yeah, well, there's a couple of robust data points in the literature that support the safety of feeding patients with compromised hemodynamic status. And I got to be careful to say that I'm not talking about feeding in the setting of somebody with deteriorating circulatory status and profound cardiovascular collapse who's on escalating doses of vasopressors, okay? Bail. Don't put any time there, they're dying. But I am talking about patients who now, as judged by clinicians, are fully resuscitated and who are on either stable or declining doses of vasopressors, that at a observational level of evidence, a robust observational level of evidence, putting something in the lumen of the gut is helpful and will be associated with an improvement in survival compared to delayed enteral feeding. And we can look to the Nutria 2 trial as a trial of two strategies, either parenteral or enteral, in patients in shock that showed no difference in survival or any other clinically meaningful outcome. And so I look at that to say, well, feeding in shock seems to be helpful and at least is not causing harm. And enteral feeding in shock is, may be helpful and not causing harm. I do recognize in the Nutria 2 there was a small increase in intolerance and in intestinal ischemia. The frequency there was like 1 or less than 1%, and it happens. And is that a random phenomena or is it a real signal? But I think if you limit your nutrition to 10 to 20 cc's an hour of a semi-digested or elemental solution in those patients with shock, and then you reevaluate carefully, and if they're off pressors in the next 24 hours, you can escalate them back up to volume-based feeding. So I'm not advocating volume-based feeding in these patients, but rather the trophic approach. I'm not advocating trophic for 7 days or 6 days. I'm advocating trophic for 24 hours with a reassessment. And I feel like that's the safest way to get some luminal nutrients in. Worst case scenario, if you're not happy with the enteral route, remember Nutria 2 showed that parenteral nutrition is of will achieve with the same clinical outcome. Point being, don't not feed somebody when they're nutritionally high risk just because they're on vasopressors.
Okay, very helpful. Another question we have is, when would you be cautious with protein delivery the first week of hospitalization?
First week of hospitalization, probably never. First week of ICU stay, the patient that causes me the greatest consternation is the patient in acute kidney injury, where the urea, creatinine, other blood work are going off and they're not quite on dialysis. And although we feel that these are catabolic patients that we shouldn't be restricting their protein intake, there are some signals in the literature that a high protein diet in this setting may be harmful. And certainly as the urea goes higher, makes me a little uncomfortable. Now, having said that, we have no RCT level of evidence of what to do in that scenario. And so I still advocate that those patients should be enrolled in a randomized controlled trial. And we aim to do a subgroup analysis of both that AKI patient pre-dialytic, as well as once you're on dialysis. People have this fixed belief that we should be giving high dose protein, but we in fact don't know that high dose protein is helpful in that dialytic phase either. And so those are two a priori subgroup analyses that we plan on doing. The only way we'll be able to get a higher level of evidence, though, is if people are comfortable randomizing them and letting fate determine whether they get a high or a usual care dose of protein, and then in the subgroup analysis, we'll have some RCT level of evidence to examine that.
Okay, great. Is there any preliminary results that you are able to share from the EFFORT trial?
The only preliminary results I could comment on are, because we track this, is the success at which we're having at meeting the protein goals. Of course, we're not going to look at outcome differences. So we aren't looking at any outcome differences, but we can say that we're still struggling to get good separation of groups. People are struggling to get into that, 2.0 range in the high dose. You can imagine how the usual care is still around 0.5, 0.6 grams per kilogram per day, but we're not happy with how much the group prescribed 2.2, how much they're getting. That might be another area where I'm certainly welcome people's comments or questions is, how are you doing it? If you're prescribing 2.0 grams per kilogram, what are your strategies for success? We don't really, the reason some people say to me, well, 2.2 is too high. And I say, well, I don't really expect you to get 2.2 in, but if we aim high and we only get 60 to 70% of that, then at least we've got 1.5, 1.6, 1.7, and that will create that separation between the two groups, where the usual care group's getting 0.5, 0.6, 0.7, 0.8. So that's the real goal, is to get maybe a gram difference between the two groups.
Let's see. I know we're running out of time. There's a question here in regards to the EFFORT trial. Can we participate in the EFFORT trial if we are continuing to use protein intake greater than 1.5 to 2 grams per kilogram? Now, this is based on actual body weight. Can you provide that data? And again, with your EFFORT trial, are you specifying then to use ideal body weight?
Only for obese patients greater than 30, BMI of greater than 30, which I think is consistent with how most people practice, but actual body weight for anybody less than a BMI of 30. And I know that many units say, oh, well, we're delivering 1.5, and I say, well, okay, that's fine for clinical reasons, but if you'd like to contribute to the advancement of science of your own practice and 4 years from now be in a better place, then you have to acknowledge or accept that we're going to randomize patients then to a little bit higher than 1.5 or a little bit lower than 1.5, create that separation of groups so we can, determine whether that higher amount of protein is of value. So you'll have to change your usual care if you're already dosing at 1.5.
I want to take this opportunity, Dr. Hyland, to thank you so much for your years and years of providing guidance for feeding the critically ill. And unfortunately, we are out of time. So we definitely thank you so much for providing such a very, very informative presentation. And we also appreciate everyone's participation today. On behalf of the Nestle Nutrition Institute, We hope that you have found this information useful to your practice and enjoy the rest of your day.